cast and you don't have crutches, it's usually what do you think of the weather. But when you're on crutches, what happens? Well, for the past week, I've been answering, I fell off a fence. Okay, now when I say that, people always react, yeah, whose fence was it? What were you doing on a fence? Sure, right. Well, I'm finally going to let you in on the real story. I broke my foot skydiving into the Grand Canyon to save the life of a small child from a pack of wolves. This morning I'm going to review some aspects of the radiographic diagnosis of intrathoracic adenopathy. I'm not going to discuss the detection and diagnosis of mediastinal adenopathy. Gary Glazer has already done that quite nicely. What I would like to do is review the differential diagnosis of mediastinal lymphadenopathy in different portions of the mediastinum, review the characteristics of several diseases associated with mediastinal adenopathy, and throw in a few miscellaneous tidbits that might be of interest regarding the diagnosis of mediastinal node diseases. Now, regarding the classification of mediastinal node groups, there are several classifications that are available if you want to localize or classify mediastinal lymph nodes. Rovier's study from the 1930s, which described lymph node groups and lymph node drainage pathways in the lung and in the mediastinum, is seminal work. His node classification scheme is a little bit complicated for me and involves a number of lymph node groups that you need to consider separately, or at least which he considers separately, which can be lumped together into a simpler format. Gary Glazer mentioned in the last lecture the ATS node station classification that is used in lung cancer staging studies, and that is its primary use. And I think in patients who have lung cancer, using this staging classification or classification of lymph node groups is very helpful. But in general, in diagnosing mediastinal node diseases, it's not all that helpful. I tend to use a classification that is based on three things. First of all, location. Of course, we're radiologists, we're looking at imaging studies, and we localize lymph nodes, so location is important. Pathophysiology, in what diseases or in what settings are various nodes abnormal, and of course differential diagnosis. And considering these three different factors, you can classify mediastinal nodes into four general groups, and using these groups or considering these groups can be of value in differential diagnosis. And these are quite simply middle mediastinal combined with hilar nodes, anterior mediastinal nodes, which are prevascular on CT, pericardiac and internal mammary nodes, which we can consider as a group, and posterior mediastinal or paravertebral nodes, which I'm only going to touch on this morning, but I'll throw in examples of those as we go along. Talking first about middle mediastinal nodes. Well, as Gary mentioned in the last lecture, these nodes are pretracheal, subcarinal, AP window. These are the middle mediastinal node groups that are generally abnormal in patients who have lymph node diseases. They represent the usual lymphatic drainage pathways from the lungs. When someone has a pulmonary disease, these are the lymph nodes that are generally abnormal. Therefore, they are usually the nodes involved in patients who have lung disease, such as carcinoma, pulmonary infections, sarcoid, of course, which is a lung disease, and silicosis. Also, these nodes are abnormal in patients who have metastases, or can be abnormal in patients who have metastases from extrathoracic tumors or lymphoma. And on your right, simply an example of a patient with sarcoid who has extensive middle mediastinal lymph node enlargement here, precarinal nodes, nodes in the aortical pulmonary window, and nodes in the superior hyla. Patients who have infectious granulomatous diseases commonly have middle mediastinal lymph node enlargement. On your left is a patient with cocci. On your right is a patient with TB. Both patients show evidence of middle mediastinal lymph node enlargement. In both patients, there are areas of pulmonary consolidation. In patients who have infectious granulomatous very nice if you do see pulmonary infection or pneumonia. At the same time, you're seeing mediastinal adenopathy, but this is not always the case. You can see adenopathy in these conditions without seeing the pneumonia that has caused it. So that, in fact, does not rule out the diagnosis of an infection. In patients who have cocci, the presence of hilar lymph nodes contiguous with the pneumonia is very common and does not have any particular significance. However, in patients with cocci, the presence of mediastinal lymphadenopathy impends dissemination. If you see mediastinal adenopathy in a patient with cocci, it's a very, very worrisome finding. This is another patient with adenopathy as a result of acute tuberculosis. We can certainly see hilar adenopathy, some widening, I think, of the right paratracheal stripe, indicating the presence of mediastinal adenopathy as well. It has been recently described that on CT in patients who have acute tuberculous adenopathy, you can see low density within the tuberculous nodes, either as a result of necrosis and fluid density within the lymph node, or if contrast has been injected, a rim enhancement with necrosis within the central portion of the node. Here, a pretracheal node in this patient with acute TB showing rim enhancement. Here, the hilar adenopathy also showing rim enhancement, and it's a little more difficult to see on the slide, but subcarinal adenopathy showing that finding as well. These low density or low central density in mediastinal nodes is a very characteristic finding with acute TB. However, it can be seen with other diseases, and I'll show you some examples in a second. Regarding sarcoid, there are just a couple points I'd like to make. Everyone's familiar with this disease. First of all, node enlargement is extraordinarily common in patients who have sarcoid and is present in about 80 or 90% of patients. The adenopathy is typically middle mediastinal and or hilar. Isolated sites of adenopathy in a patient with sarcoid are rare. Middle mediastinal lymphadenopathy without hilar involvement is a rare finding. If you see mediastinal adenopathy and the hila are normal, you should think of something other than sarcoid. Anterior mediastinal nodes, that is prevascular nodes, are present in 15 to 20% of patients with sarcoid, but again would be rare as an isolated site. Similarly, posterior nodes can be seen, but would be rare as an isolated site. Unless you see hilar and mediastinal adenopathy, middle mediastinal adenopathy, you are probably dealing with something other than sarcoid. Well, here again, a patient with rather typical adenopathy from sarcoid, bilateral hilar nodes, anterior or pretracheal lymph nodes, nodes in the lateral superior AP window, and here a prevascular or anterior mediastinal node. Here at lower levels in this patient, again, extensive mediastinal adenopathy here in subcarinal space, AP window on the left, subcarinal space, and within the hilar, again, extensive adenopathy. A very typical appearance of mediastinal and hilar adenopathy in a patient who has sarcoid. Well, how about this patient? We certainly see a mass within the right mediastinum. The hila don't definitely look abnormal on the frontal radiograph. Perhaps there's some fullness anteriorly on the lateral view. But looking at the lateral view, it seems as if most of the mediastinal mass is anterior in location. If we look at CT in this patient, we can see indeed that there is extensive anterior mediastinal adenopathy in addition to pretracheal nodes and nodes in the upper portion of the AP window. Well, I think with this extensive anterior mediastinal adenopathy, we should think of something other than sarcoid. But again, remember that in 15 or 20% of patients, you will see adenopathy in that portion of the mediastinum associated with middle mediastinal nodes. And indeed, on biopsy, this was sarcoid presenting with a lot of bulky anterior mediastinal adenopathy. This is an example of a patient who has sarcoid and posterior mediastinal nodes. You can see a couple lobulated nodes adjacent to the paravertebral stripe on the left side. No evidence of mediastinal adenopathy up high, probably some left hilar adenopathy. A rather unusual occurrence in a patient with sarcoid, but something you will occasionally see. Eggshell calcification was mentioned by Phil Goodman earlier this morning. While I was researching this talk, I found out that there are specific criteria for making the diagnosis of eggshell calcification, and this is them. You must see shell-like calcification 2 millimeters thick in the periphery of at least 2 nodes. It must have a complete ring-like appearance in one of the nodes. Calcifications of the central portion of the node can also be present, and the nodes should be enlarged. Well, I'm not sure we need to remember these or only call eggshell calcification when we see those criteria, but indeed, this is what eggshell calcification is. This is a patient who has silicosis and rather nice eggshell calcification within right hilar nodes. We're seeing these ring-like peripheral calcifications of the lymph nodes. It's a very characteristic finding in patients who have silicosis. It does, however, have a differential diagnosis. Silicosis, with sarcoid being the second most common cause, node calcification being present in about 5% of patients who have sarcoid. Post-irradiation Hodgkin's disease results in node calcification. Occasionally, it will be eggshell. Fungal infections will show this finding. TB, amyloid, and scleroderma rarely show this finding. Phil showed this slide earlier this morning. This is a patient with sarcoidosis who had a eggshell calcification up here that someone sat on. But I think down here we are seeing an eggshell calcification in this inferior hilar node. And indeed, sarcoid is not an uncommon cause. This is a patient who presented with neck vein distension and some rather diffuse chest pain. On the plain radiograph, I think the most spectacular finding is that the right hilar pulmonary artery is markedly reduced in size as compared to the left pulmonary artery, and intrapulmonary vessels within the right lung are also rather small. Looking at the mediastinum, there's perhaps some widening of the paratracheal stripe, but otherwise the mediastinum does not look all that abnormal. Well, this is CT in this patient, and it's quite surprising how extensively calcified mediastinal nodes are in this patient at contiguous levels from the upper portion of the mediastinum down to the lower portion of the mediastinum. And quite clearly, this is a patient who has extensive calcified mediastinal nodes as a result of granulomatous disease. In this patient, it was histoplasmosis. And this is what we would call granulomatous mediastinitis. Now, the reason we would call this granulomatous mediastinitis rather than simply mediastinal node calcification is that these calcified nodes and the related fibrous response in the mediastinum has resulted in obstruction of the superior vena cava, and you can see calcified clot within the lumen of the SVC, and has also resulted in obstruction of the right pulmonary artery, giving the appearance we saw on the chest radiograph. Note that this is the level at which we probably should be seeing right pulmonary artery cross the mediastinum, and all we're seeing are these bunches of calcified mediastinal nodes. This is a dynamic series performed at that level, and notice right pulmonary artery is obstructed by these granulomatous nodes and the associated fibrous response. Intrathoracic lymph node metastases are commonly middle mediastinal. In a study reported by Teresa McLeod in 1978, among the patients she studied who had mediastinal adenopathy, hilar nodes and paratracheal nodes were certainly most common. Anterior mediastinal nodes also were seen, but less common. Posterior mediastinal and subcarinal adenopathy much less common in her series. The tumors that tend to do this are tumors of the GU tract, particularly renal cell carcinomas and testicular carcinomas, head and neck tumors, breast carcinoma, and melanoma in that order. On your right is a patient who has a renal cell carcinoma and a large bunch of right hilar nodes as a result of metastatic tumor from the renal cell. These are two patients with melanoma. On your left is a patient who has obviously a large mass within the lung, another little mass sitting down here, right hilar adenopathy, and a very large right paratracheal mass. On your right is a patient with a lower extremity melanoma who is presenting with posterior mediastinal adenopathy, again adjacent to the aorta or paravertebral stripe. And these two cases illustrate the two potential ways that you can develop mediastinal node metastases in patients who have an extrathoracic tumor. In some patients with an extrathoracic primary tumor, you can develop hilar and mediastinal nodes as a result of a pulmonary metastasis. This is exactly analogous to developing hilar and mediastinal nodes secondary to a lung cancer. The first metastasis perhaps is here, spread to hilar nodes, spread up the paratracheal chain. It would not be unusual in such a case to also see lymphangitic spread of carcinoma. That's not visible in this patient. In this person who has a lower extremity melanoma, I believe these posterior mediastinal nodes are as a result of spread of tumor up the lymphatic channels in a paravertebral location, and undoubtedly there were abdominal lymph nodes as well in this patient. Now this is an unusual case, and I'm not sure this projects particularly well, but this is a patient who had a cystadenocarcinoma of the ovary, who had multiple metastases to the abdomen and to the mediastinal lymph nodes. And we can see that these abdominal metastases are calcified, as was the primary tumor. And certainly certain kinds of adenocarcinomas, calcification does occur. But notice that these mediastinal lymph node metastases are also calcified. And tumors that form calcium or have psammoma bodies that calcify, that do metastasize to mediastinal nodes, can indeed show node calcification. This is a patient who has a breast carcinoma that is metastatic to mediastinal lymph nodes. Notice that there is a subcarinal mass of lymph nodes that we can see on 2 adjacent CT scans. And as in the patient who had acute adenopathy from tuberculosis, this lymph node mass is low density in the center with rim enhancement. So this is a necrotic rim-enhancing lymph node occurring in a patient with metastatic tumor. This sort of low-density mediastinal node metastasis has also been reported in patients with carcinoma. Moving now to anterior mediastinal lymph nodes, the differential diagnosis changes a little bit. Now, first of all, by anterior mediastinal nodes, I primarily mean prevascular lymph nodes as seen on CT. I'm also going to talk about pericardiac and retrosternal or internal mammary lymph nodes, but I will do those separately in just a moment. The differential diagnosis of anterior mediastinal nodes includes a number of things which, of course, you're familiar with: lymphoma, breast carcinoma, because of its close association, metastases from extrathoracic primary tumors, and bronchogenic carcinoma. Now, Gary mentioned bronchogenic carcinoma in the last lecture, and he talked primarily about middle mediastinal lymph nodes, but you can have anterior node metastases in patients with lung cancer. Node metastases in about 30% of cases with lung cancer, usually middle mediastinal nodes, but anterior mediastinal carcinomas can be seen. It has been suggested by some authors that these are primary mediastinal carcinomas. Now, that's something that I have some trouble understanding, but that is something that is bandied about in the literature, that these anterior mediastinal bronchogenic carcinomas are occurring primarily in that location without there being a lung mass associated. These primary anterior mediastinal carcinomas are often anaplastic tumors, anterior mediastinal, as I've said. In one review of 2,400 primary mediastinal masses, about 5% were considered to be one of these so-called primary mediastinal carcinomas. In another study, 11 of 170 anaplastic lung cancers had no visible primary lesion within the lung, but presented with a mediastinal mass. In 8 of those 11 patients who had anaplastic carcinoma and a mediastinal mass with no lung lesion, the lesion was anterior mediastinal. So you can sometimes see anterior mediastinal bronchogenic carcinoma without there being a lung lesion, and it will very closely mimic what you should see in a patient with lymphoma. This is an example, a patient with node cell carcinoma presenting with a very large anterior mediastinal mass, no evidence of a primary tumor in the lung. Is it a primary mediastinal carcinoma? I'm not sure. Hodgkin's lymphoma results in node metastases in 85% of cases. This is nothing new or radical, but simply a review. The lymph nodes you see in patients with lymphoma are typically prevascular, that is anterior mediastinum, pretracheal, and involving the AP window. If these lymph node groups are uninvolved, question the diagnosis of Hodgkin's lymphoma. It is very, very uncommon to have Hodgkin's without involvement of these nodes. That is associated with some other intrathoracic abnormality. Subcarinal or hilar nodes in about half of patients. A single node group can be seen in patients with Hodgkin's disease in about 15%. That's usually anterior mediastinal and usually in patients with nodular sclerosing Hodgkin's disease. Now, that would be a reasonable assumption in any patient you saw with Hodgkin's disease, because 85% of patients who have adult Hodgkin's disease have nodular sclerosing disease. These are results from a study published by Ron Castellino regarding the distribution of lymphadenopathy in patients with Hodgkin's disease who are presenting for their initial staging. In his study, he looked at 200 patients, and about 80% were nodular sclerosing Hodgkin's. Superior mediastinal nodes, and by that he means pretracheal or anterior mediastinal nodes, were involved in about 85% as seen on CT. And you can see the range of values for involvement of other lymph node groups down below. Plain radiographs, we should note, were most accurate in diagnosing the superior mediastinal adenopathy or hilar adenopathy, and were much less accurate in diagnosing subcarinal pericardiac or posterior mediastinal adenopathy. Now again, I want to emphasize how common involvement of these lymph node groups are. In his study, 98% of patients who had intrathoracic disease had involvement of these superior mediastinal nodes. So if uninvolved, question the diagnosis. This is a rather typical appearance for anterior mediastinal lymphadenopathy in a patient with Hodgkin's disease, with the exception that the patient also has a right aortic arch. But we can see several discrete and large lymph nodes in the prevascular mediastinum. Other lymph node groups in this patient seem to be uninvolved. This is a patient with, again, an anterior mediastinal lymph node mass as a result of nodular sclerosing Hodgkin's. In patients who have Hodgkin's disease, the lymph nodes can become matted together into a single large mass. And in patients with Hodgkin's, necrosis within these matted lymph node masses is not uncommon, as we see in this patient. And you can see this sort of low density within mediastinal lymph nodes in other locations in patients with Hodgkin's disease as well. This is a young patient who has ataxia telangiectasia syndrome, a syndrome which results in an immune deficiency, and this patient developed lymphoma as a result of this syndrome, very common in ataxia telangiectasia. I think about 10% of patients develop lymphoma. And we can see extensive mediastinal adenopathy, right hilar, anterior mediastinal, pretracheal, and subcarinal. And note that the subcarinal node, I think, is a little bit low in density. You might have some suggestion here of rim enhancement. Again, a low-density mediastinal lymph node here in patients with Hodgkin's. Posterior mediastinal adenopathy can be seen in Hodgkin's disease. In this patient, it seemed to be an isolated lymph node abnormality. There was no other evidence of lymphadenopathy on a chest radiograph. This would be a very unusual presentation for Hodgkin's. Just a brief word about non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma represents really a diverse group of tumors. It's not a single tumor type. It's typically seen in older patients than is Hodgkin's disease. A large majority of patients, about 85% of patients who have non-Hodgkin's lymphoma, are stage 3 or 4 diagnosis, and because of that, anatomic staging is not as crucial as it is in Hodgkin's disease. Therefore, you may not end up doing CT or other staging studies in patients who have non-Hodgkin's lymphoma. A single node group is involved more commonly than in patients with Hodgkin's, and posterior mediastinal nodes are more commonly involved than in Hodgkin's disease. Anterior lymph nodes being less common. So the distribution of the disease may be a little bit different, but again, this is not always a group that you end up looking at using CT. This is a patient who shows calcification of mediastinal lymph nodes after radiation for Hodgkin's disease. This is a rather common appearance, but I showed this slide to make 2 points. One is that you can see node calcification like this in patients with untreated Hodgkin's disease. Patients can present with Hodgkin's disease and node calcification. The presence of calcium within lymph nodes does not always indicate that you are looking at a granulomatous or benign process. The calcification you can see in patients without treatment can look like this, which is rather fleck-like or mottled appearance, or it may be much more subtle calcification with only very small portions of the tumor being calcified. The second reason I want to show this is to make the point that patients commonly, after treatment, still have enlarged lymph nodes in their mediastinum or residual mediastinal masses, which can be detected either on plain radiographs or CT. In several studies looking at plain radiographs in patients who have had treated Hodgkin's disease, these residual masses are present in up to 80% of cases, but there's a tremendous range from about 20 to 80% of patients that have been studied. It has been suggested that MR may be valuable in evaluating these residual mediastinal masses or residual enlarged lymph nodes in patients who have had radiation for Hodgkin's disease. The reason being that after radiation, these residual node masses consist primarily of fibrous tissue and therefore should be relatively low in intensity on T2 weighted images as compared to what the tumor looked like before treatment. Well, this is a patient who has a Hodgkin's lymphoma in the upper mediastinum on a T2 weighted MR image. Compared to this T2 weighted MR image after treatment, you can see that the mass is not only much smaller, it's much darker or lower in intensity. And this is what we would expect to see in patients with a post-radiation Hodgkin's lymphoma MR image. Pericardiac and internal mammary lymph nodes are very closely related. The internal mammary nodes are shown here quite nicely in this diagram, being on each side of the sternum. Inferiorly, they communicate with a group of lymph nodes that outline the heart on the surface of the diaphragm. These are the so-called pericardiac lymph nodes. Now, the pericardiac lymph nodes, quite simply, can be divided into an anterior group and a posterior group, which are anterior and posterior in location, very easy to remember. Differential diagnosis of pericardiac lymph node enlargement involves metastases primarily and lymphoma, with lymphoma being far and away the most common cause. This is a patient who has a Hodgkin's lymphoma and involvement of two pericardiac lymph nodes, this being the inferior vena cava. But here two very nicely seen enlarged pericardiac nodes. Here a patient with a mass in the right cardiophrenic angle. Could be a pericardial cyst, could be a large fat pad, mosaic hernia, or something like that. But in this patient, it was a large mass of anterior pericardiac nodes as a result of metastatic hepatoma. A recent study reported in Radiology reviewed 21 cases of 21 patients who had cardiophrenic angle adenopathy detected on CT, and radiographs were abnormal in only about a third. So radiographs are very insensitive in diagnosing lymph nodes in this portion of the spine. And as a rule, lymph nodes less than 3 centimeters are not detectable on plain film. So these have to get pretty big before they're recognizable. 60% had lymphoma. The remainder had a metastatic tumor above the diaphragm or below the diaphragm. Now this is just a plain film example to show you how difficult these pericardiac nodes can be to detect. This is a patient who had prior mediastinal radiation for Hodgkin's disease, and the mediastinum is radiated in these patients. The heart is usually excluded from the treatment field to avoid radiation pericarditis. Therefore, the pericardiac nodes are not radiated, and if the lymphoma recurs, it probably or may recur in the pericardiac node. Well, in looking at this chest film without access to old film, we thought the woman had sort of a mildly big heart. About that.